as we all know that, cystic lung diseases is something that we either overlook or underlook. So it's important to understand the basic aspects, know the common presentations, and how to proceed. So cystic lung disease is the terminology which is used when multiple cysts are seen in bilateral lungs. A pulmonary cyst is any circumscribed air containing structure in the lung parenchyma with a thin, less than 2, less than 3 and it usually has a regular wall. This terminology, mind you, is not used for cysts like the bronchogenic or the hydrated cyst. So there are many, many causes of cystic lung disease. When you look at the neoplastic causes, you have the pulmonary Langerhans cell histiocytosis, lymphangioleiomyomatosis, genetic, developmental, or congenital like the Birt-Hogg-Dubé syndrome, cysts with lymphoproliferative disorders like the LIP, then various infections, staph, pneumocystis cerevisiae can have cystic presentation. Then associated with ILD, you would have hypersensitivity pneumonitis and even desquamative interstitial pneumonia. Smoking related, again, PLCH and desquamative interstitial pneumonia, as well as respiratory bronchiolitis. So usually the presentation is asymptomatic. Patient can present with cough, maybe dyspnea with on exertion. A lot of them present with spontaneous pneumothoraces when they present to you in the hospital, and it's retrospectively found out that there is a cystic lung disease. They would have sudden onset shortness of breath if it's a spontaneous pneumothorax. So always remember, it is important to understand, to look at any CT for any patient with any underlying disease. You should have a systematic approach. Let's look at the cystic lung diseases with a stepwise approach. So step one includes excluding the mimics. Always look for mimics. Rule out the possible similar presentations and rule out whether it's actually a true cyst or not. So what are the mimics of cystic lung disease? There can be honeycombing, and honeycombing, we've been talking about it in the last three lectures about ILDs, and we've talked a lot about honeycombing. We know it is very typical in UIP, seen in IPF. So it's multi-layered honeycomb cysts. They're associated with interlobular septal thickening. They have a subpleural, peripheral, and basal predominance. Then cystic bronchiectasis can be focal or diffuse depending upon the etiology. Then centrilobular emphysema, cystic air spaces without a wall, and they generally have an upper lobe predominance. Then various post-infective cases also you can have cystic kind of presentation. Then paraseptal emphysema, cysts that are adjacent to pleural surfaces, uh, bullae, which are round focal lucency of or decreased attenuation of more than 1 centimeter in size, and adjacent lung shows emphysematous changes. They can also be focal and diffuse. Cavities and also cysts can occur in active infection like pneumocystis cerevisiae, staphylococcal infection. So you need to always remember that when you have a patient with a CT presentation, a cyst-like presentation, rule out mimics. That should be the step one. Then when you look at the CT, is it an incidental finding? In a young patient with lung cyst, it should not be regarded as normal. As a rule of thumb, they say that up to 4 cysts in a patient over 40 uh, can be an incidental finding, but do not hold this rule as a rule of thumb, and just don't stick to it. And always remember that there is a clinical presentation, there's always a clinical correlation. Look at the presentation, look at the CT, correlate, and then rule out that if there are actually up to 4 cysts in a patient over 40, it might be an incidental finding. So you've ruled out mimics, you've looked at whether it's actually a pathological or an incidental finding. Then the four most common cystic lung diseases that are there and we are going to be discussing today is your lymphangioleiomyomatosis, pulmonary Langerhans cell histiocytosis, Birt-Hogg-Dubé syndrome, and lymphoid interstitial pneumonia. So after ruling out the mimics and then looking at you've identifying whether it's an incidental finding or it's actually pathological, you look at the differences, you look at the presentation. So are there any associated nodules? Specifically, like you see in this axial cut, nodules, upper lobe predominance. commonly seen in Langerhans cell histiocytosis. Then cysts with a background of ground glassing seen on this axial cut. So, you would have this presentation in LIP as well as DIP. The history would be different. An LIP patient would have an associated history of autoimmune disease, whereas a DIP, desquamative interstitial pneumonia patient would have history of smoking. So, clinical cues are always important. Always remember your histories. And then again, no nodules or ground glassing, diffuse presentation, no zone predominance, seen seen in cases of LAM. It can also be seen in LCH, Birt-Hogg-Dubé as well as LIP. Then there are certain cyst patterns which are associated with specific conditions, like thin wall, round to oval are seen in LAM. Periseptal lenticular shape is very characteristic for Birt-Hogg-Dubé. Then irregular bizarre shape because they cysts keep confluenting. They keep seen in LCH. Then vascular indentations are seen in LIP. Then nodules with the Cheerio sign when they cavitate, when there's a central lucency, is seen again in LCH. Then associated with ground glassing, like I said, LIP and DIP. Characteristic history helps you to differentiate. So cyst patterns with specific presentations are also very characteristic for the underlying cystic lung diseases. Now, distribution also helps you determine the etiology. Like LAM cysts are usually evenly spread and they are numerous. Then Langerhans cell histiocytosis would have an upper lobe preference, and the pleural recesses are typically preserved. Then in BHT, LIP, and DIP, there is a lower lobe preference, and there are usually fewer cysts. Then there are certain patient characteristics also. For example, in lymphangioleiomyomatosis, you would have women in childbearing age, maybe on the in the abdominal CT with the tuberous sclerosis presentation. There might be presence of angiolipomas. They can present with spontaneous pneumothoracis. Langerhans cell histiocytosis patient would have a history of smoking. There's always a high risk of lung cancer. Sometimes it is retrospectively found out in lung cancer patients. Then Birt-Hogg-Dubé syndrome would have a family history of recurrent spontaneous pneumothoracis, renal cancer in first and second degree relatives. LIP would be associated with autoimmune diseases, retroviral disease, and DIP would have a smoking relation. So remember the mimics, remember to rule them out. See your cyst, look at the incidental or there's a pathological finding, rule out the differentials, look at the associated findings, look at the zone predominance, upper or lower, number of cysts. Then, of course, patient history, patient characteristics, presentation is also very important. Now, let's look at the first cystic lung disease, which is lymphangioleiomyomatosis. It's a progressive disease. Patients are usually symptomatic with dyspnea, cough, chest pain, and hemoptysis. Some of them can present with spontaneous pneumothorax, pleural effusion, chylothorax in case of lymphangioleiomyomatosis, and also angiolipomas. Now, look at these four axial cuts. You can see numerous cysts present diffusely. They don't have a zone predominance. Then this was um, again very severe, very large cysts seen. Now, differential could be LCH, but with this particular history with a woman of childbearing age, the differential diagnosis of LCH was ruled out. Then there's a pleural effusion in this patient of LAM. Usually, chylous effusion is seen in cases of LAM. Then again, cysts with diffuse distribution. So history is very important in cystic lung diseases. Then this was a 39-year-old female with acute onset shortness of breath. As you can see, there are multiple thin wall cysts, and they are evenly spread out throughout the lung fields. There's also, pleural recesses are involved, which actually rules out the LCH, and the diagnosis of LAM is evident in this patient with the characteristic history presentation and the female. Then LAM is the only cystic lung disease which presents with a combination of pleural effusion, presence of a chylous effusion, because the LAM cells can lead to blockage of the lymph system in the chest to create a chylous effusion. Then there is a variant of LAM called the tuberous sclerosis complex, which is a rare form. It's a genetic disorder causing benign tumors in multiple organs like brain, skin, kidneys, and lungs. There are various skin manifestations like the ash leaf macules, chagrin patch, facial angiofibroma. Then there can also be involvement in other organs. Imaging shows diffuse bilateral thin walls cysts throughout the lung fields, and multiple angiolipomas can also be seen. So this was a severe LAM with diffusely affected lung parenchyma, and this was multiple angiolipomas was seen in the upper abdomen. And with the tuberous sclerosis complex LAM variant, there is about 80% prevalence of angiolipomas. And in sporadic LAM, only 40 to 50% angiolipomas are seen. Then, so the key point in tuberous sclerosis LAM variant is basically cystic changes often coexist with other TSC manifestations. So LAM would have similar presentation, but then the other skin manifestations would also, or brain and kidney manifestations may also be present in the tuberous sclerosis complex variant. So diagnosis would be based on your clinical features, progressive dyspnea, spontaneous pneumothorax, maybe a presence of chylous effusion. Abdominal scan may show angiolipomas. CT would have characteristic thin-walled, uniformly distributed uh, cysts on the HRCT chest. Pulmonary function test would have an obstructive pattern or a reduced DLCO. And biopsy would show smooth muscle proliferation, cystic destruction. In suspected cases, you can check for the vascular endothelial growth factor D levels. And for tuberous sclerosis complex, we look at the genetic mutations, the TSC1 and TSC2 mutations. So when you look at the differences in sporadic and tuberous sclerosis LAM, sporadic are usually always symptomatic and they have a progressive lung disease, and tuberous sclerosis are usually mostly asymptomatic. Angiolipomas are common in the tuberous sclerosis, whereas chylous effusion is more common in sporadic. CNS involvement is seen in tuberous sclerosis. Pneumothorax may be seen in both, and treatment is with sirolimus, and ultimately it's the lung transplant. Then the next cystic lung disease that we're going to look at today is the pulmonary Langerhans cell histiocytosis, which can occur in two forms, that is the isolated pulmonary involvement or as a part of the systemic involvement. Uh, Pulmonary involvement occurs most commonly in young adults who are smokers. And clinical features is generally 20 to 40 years of age with the characteristic history of smoking. Patient may have dyspnea and a non-productive cough on as a presenting symptom. And they can also have fatigue, chest pain, weight loss, and even a spontaneous pneumothorax on presentation. So, uh, look at these four axial cuts. And usually, smoking is a history in PLCH patients. They usually start with nodules that cavitate, and they can form, they can, also form irregular, bizarre cysts. You can see, as in this axial cut, there are irregular, bizarre cysts. Look at this axial cut with diffuse, sorry, cysts throughout. This could easily be confused with a lamb, but this not being a woman and not in the characteristic history of smoking, this was a case of PLCH. Then nodules over here in this coronal cut. And if you look here, there are bizarre looking cysts and nodules, and there's also something known as a Cheerio sign. So Cheerio sign is basically the nodules that cavitate, and there's a central lucency, if you can appreciate here. And this is because there's a patent bronchus. So this is also seen in PLCH. Then again, over here, there are bizarre looking cysts, there are nodules. There's again the Cheerio sign, the nodule is cavitating. Another case wherein the cysts are predominantly in the upper and middle zones. There is basically pleural recesses are preserved, and the cysts have also caused a pneumothorax. So in the early disease, the CT features are basically small, irregular shaped nodules, which have a centrilobular peribronchial and peribronchiolar distribution. Upper and mid zone lung predominance. Generally, the uh, lower zones and the CP angles are spared. Lung volumes are relatively preserved. And in the later stages, it is the cystic pattern that dominates. So cysts that are irregular, small, and sometimes bizarre shaped. Bizarre shaped cysts are seen commonly in pulmonary Langerhans cell histiocytosis. And then also the octopus sign, which is the central fibrotic scar with adjacent areas of paracicatricial airspace enlargement is also seen in PLCH. So diagnosis basically involves clinical features, history of smoking, characteristic HRCT finding, PFT, and 5% of the CD1A positive cells on BAL, which is highly suggestive of the disease. And also, biopsy, when done, shows proliferation of Langerhans cells with occasional clustering of eosinophils. So, when you look at the differences between pulmonary Langerhans cell histiocytosis and LAM, as you can see, this presence in the earlier years, 20 to 40 years, and male and female can have equal can be present equally. Sorry. Then LAM occurs in females. Bizarre looking cysts. They generally have cysts which are round and uniform. Then PLCH is generally an upper mid zone. There is no zone predominance. And other findings include pneumothorax, and there can be a chylous effusion along with a pneumothorax in LAM patients. Treatment is basically with smoking cessation, glucocorticoids, cytotoxic drugs, and of course, and at the end, lung transplantation. The third cystic lung disease that we're going to look at is the Birt-Hogg-Dubé syndrome, which is an under-recognized entity. It is an autosomal dominant inherited disease. Presentation is with multiple lung cysts. There can be cutaneous manifestations with fibrofolliculomas. There can be spontaneous pneumothorax and renal cancer. It occurs because of mutation in the FLCN gene 17, and identification is increased because of the availability of the genetic testing. So something very characteristic about this is always ask for history of pneumothorax or renal cancer in first and second degree relatives. Usually these patients have a very characteristic family history, and renal cancers and bilateral renal tumors occur in more than 25% of these cases. Various cutaneous manifestations are also seen, and they abut or encase proximal pulmonary veins. So, like I said, it's an autosomal dominant, and there is generally lower lobe predominance, peripheral predominance. Like in this case, you can see the cyst is towards the periphery in the mediastinum. Then lower zone predominance is generally seen in Birt-Hogg-Dubé syndrome. They will have a family history of a renal cancer or a pneumothorax. So the cysts are located in the periphery, like I showed, near the mediastinum, and they are also close to the fissure. So these are some characteristic presentation of Birt-Hogg-Dubé. Skin lesions like fibrofolliculomas, the trichodiscomas, and the acrochondrons are also a finding which is seen in Birt-Hogg-Dubé syndrome in the cutaneous manifestations. So when you have the characteristic presentation along with cysts on your HRCT chest, with characteristic history of renal carcinoma or maybe recurrent pneumothorax in family, then skin lesions are present, you would need a skin biopsy. In the absence of skin manifestation, an FLCN gene analysis may be required. BAL will show lymphocytosis, and definitive diagnosis usually require a surgical lung biopsy. So for diagnosis, the characteristic family history, clinical features, characteristic imaging features, and depending upon the presentation, you would do the investigation to reach the diagnosis of Birt-Hogg-Dubé syndrome. Now, another cystic disease, which is the lymphoid interstitial pneumonia, is a disease of unknown etiology, and it is characterized by infiltration of lymphocytes. It is associated with systemic diseases, especially Sjogren retroviral HIV disease, and common variable immunodeficiency. It can present as simple cysts, but more often in combination with ground glass reticulation and nodules. So a patient with characteristic ground glass in the background with presentation of cysts, you think of LIP or DIP with a characteristic history of associated autoimmune disease or a retroviral disease. You think of more of LIP as the underlying diagnosis. So as you can see in these axial cuts, there is diffuse ground glassing in the background and presence of cysts along with the ground glassing seen in all the axial cuts. So this was actually a case, as you can see in both the axial and the coronal cut, there is ground glassing with cysts present. This was a female with a 55-year-old female with dyspnea. She had a history of mixed connective tissue disease. So in this background, with this presentation, the diagnosis of LIP was made for this patient. Again, this was a 60-year-old female with Sjogren syndrome as an underlying disease. And she had this presentation with ground glassing and cysts. And so the diagnosis of LIP was made for this patient. Now, desquamative interstitial pneumonia has a strong association with smoking. It is often associated with signs of fibrosis. So this was a 65-year-old female with shortness of breath and a history of smoking. And as you can see here, there are thin wall cysts. There is also fibrosis, and there's also traction bronchiectasis seen here, again in the background of ground glassing. So this is how it is differentiated from LIP. So this was a case of desquamative interstitial pneumonitis. Again, uh, history is very important to differentiate between LIP and DIP. And the cysts are generally in the periphery of the lower lung fields, and frequently they are combined with fibrosis in DIP. So, once we've talked about all these diseases, you've heard about their presentations, their characteristic histories. How do you reach a diagnosis? Clinical features and imaging is usually enough. When you have characteristic features for your cases of lymphangioleiomyomatosis or pulmonary Langerhans cell histiocytosis or desquamative interstitial pneumonia. Then serology is important with characteristic clinical presentation and underlying history for retroviral diseases, connective tissue diseases, vascular endothelial growth factor D in certain cases of LAM. Then you may need to take biopsy from extrapulmonary sites in cases of Sjogren's, LCH, even BHT. There are skin manifestations, genetic gene mutation studies, if available, for testing for the FCL17 gene. Then cryobiopsy, transbronchial cryobiopsy is what is preferred biopsy these days for in case you have to do a biopsy for cystic lung diseases. However, wherever it is not available, the expertise is not available, then of course surgical lung biopsy can be done to reach the diagnosis in cystic lung diseases where it is indicated. So when you have a patient with diffuse cysts present throughout the lung fields, female, young, you would think of LAM. Then again, a patient with characteristic history, and you can see peripheral predominance close to the mediastinum cystic structures, you would think of BHD. Of course, BHD would have characteristic history as well, which is very important. Then ground glassing in the presence of background of ground glassing with cysts, with autoimmune diseases and underlying presentation, you would think of LIP. And then again, bizarre looking cysts would be seen in pulmonary Langerhans cell histiocytosis. So let's look at the stepwise approach again. When you have a patient with cysts on your CT, you first have to see whether it is actually a true lung cyst or is it a mimic. Look at all the causes like bulla, emphysema, honeycombing, bronchiectasis, cavitations, infections, vasculitis. Then once you've ruled out the mimics, look at the cysts, whether they're an incidental or a pathological finding. Remember the rule of 4 and 40. Then look at the associated findings to rule out the differentials and reach the specific diagnosis, whether there are any nodules or not. If yes, then probability of Langerhans cell histiocytosis is more. Ground glassing seen in both LIP and DIP. History helps you to differentiate. No nodules or ground glassing can be seen young female, childbearing age, LAM. Also can be seen in LCH, BHD, and LIP. There are various uncommon causes of cystic lung diseases as well, like cystic metastasis, light chain deposition diseases, cystic hypersensitive pneumonitis, as well as neurofibromatosis type 1. So, light chain deposition disease occurs as a complication of lymphoproliferative diseases or as a precursor of multiple myeloma. Typically, thin walled cysts show nodular thickenings. If you can appreciate nodular thickenings, so these are uncommon causes. Just to show you a few of them, there are nodules here around the cysts. If you can appreciate, they're present on both the sides. Then thymic carcinoma, this was actually a case, and that is how, usually there is generally metastasis with nodules or cavities. but there can be in very rare presentation cystic metastasis. So this was a case of thymic carcinoma and had cystic metastasis like this. Then again, when you look at these axial cuts, you look at ground glassing with cysts and you think of DIP and LIP. But in a patient with characteristic pigeon exposure or diagnosis of hypersensitive pneumonitis, that is how this cystic hypersensitive pneumonitis diagnosis was made. Then benign metastasizing leiomyoma in a woman with a history of uterine leiomyoma. You can see few thin-walled cysts with combination of nodules. There are nodules, and there is again the Cheerio sign that can be seen here, over here. There are nodules. So underlying condition is actually very important. Again, in neurofibromatosis type 1, there is specific bullae in the upper fields, and then there are multiple scattered cysts throughout the parenchyma, including the pleural recesses. So combination of both upper field bullae as well as middle and lower field cysts is typically seen in neurofibromatosis type 1, and there can be some associated fibrotic changes also. So to summarize, remember that when you are looking at a patient with cystic lung disease, step one, exclude mimics. Look at the possibilities, assess the significance, whether it's an incidental or a pathological finding. Correlate associated findings of nodules, ground glass, whether there are no nodules or ground glass, specific conditions. Then LAM will have uniform thin-walled cysts, diffuse distribution. Women of childbearing age may have a chylous effusion in a few cases. Birt-Hogg-Dubé would have fewer lenticular or peripheral cysts, basal and peripheral predominance, recurrent pneumothorax, renal history tumor, recurrent pneumothorax history in first and second degree relatives. Langerhans cell histiocytosis would have an upper and mid zone predominance, bizarre looking cysts. There is sparing of the CP angles, and it is a smoking related cystic lung disease. LIP would have a lower lobe cyst with ground glassing, septal thickening. Autoimmune disorder is always associated, and that's how you differentiate it from DIP. Again, DIP would also have lower lobe predominance, peripheral cysts, ground glassing, with smoking is associated, and fibrosis is also seen in DIP. Then there are various uncommon causes as well, but the underlying cause usually helps you to determine the etiology of the cyst. Always remember to look at the clinical history, look at the age of presentation, gender of the patient, any smoking history, family history, whether any associated skin lesions, autoimmune disorders. Always correlate clinically. Do not try to jump to conclusions by just looking at the CT scan. Complications, these cysts are associated with complications that are detected on imaging. And there are pitfalls and challenges in the diagnosis, so you always require a clinical, radiological, and pathological approach. Systemic evaluation of morphology, distribution, and associated findings, integrated with history, remains critical for accurate diagnosis and target management of cystic lung diseases. These were my references. Thank you.